Let's talk. Your health and wellness podcast.
Hi, everyone. Welcome to Let's Talk, Soul Food, where we nourish your mind, body, and soul with conversations that empower and educate. Today's hot topic is making waves around the world and globe: weight loss medications and injectables like Ozempic and Mounjaro. Today, we're joined by Dr. Charlene Wolberg, alongside our regular panelist, Mike Hughes, and of course myself, Dr. Avron Urison, to help you unpack this really interesting topic. Dr. Charlene Wolberg is a highly respected medical doctor with over 2 decades of experience in the field of obesity medicine. Dr. Wolberg qualified with a medical degree from this university in 1992 before joining the South African Institute for Medical Research in the Department of Chemical Pathology. And it was there that her passion for obesity medicine was ignited, a journey that would see her obtained a master's degree in nutritional sciences from the University of Stellenbosch in 2013, and spent time at internationally renowned obesity clinics, including Luton Clinic in the UK and Cleveland Clinic in the USA. In 2000, Dr. Wolberg opened one of the first private practices in South Africa dedicated to treating obesity as a disease state, offered a multifaceted approach to weight management, and with numerous talks and media appearances and articles under her belt, Dr. Wolberg continues to advocate the importance of evidence-based compassionate care for those struggling with weight and metabolic health. Currently practicing at Netcare Linksfield Clinic, Charlene's with us this evening, and we're very privileged to have you with us, Charlene, to unpack the latest in weight loss medication, including Ozempic, Mounjaro, and other injectables, separating fact from fiction and helping us better understand how these treatments fit into the bigger picture of health and wellness. Wow, Charlene, that's a big intro. And as I said, very privileged to have you here and for you to share the knowledge with us this evening. So welcome onto our podcast.
Thank you so much. And thank you so much for inviting me onto your podcast this evening.
Great. So, and Mark, as always, so great to have you here. You and I have talked about this a lot, and we've said we need to bring an expert onto our podcast. So here we are, and hopefully with your help, we can help unpack this topic.
Yeah, this is an exciting one I've looked forward to for a long time.
Great. So I think let's set the scene here, and Charlene, you can add in. I mean, as I read in your resume, I mean, this has been an area of your expertise and knowledge, but injectables have only really come in the last few years. I'm going to ask you to verify and tell us if that's true, and maybe we can just set the scene here. Why is there such popularity around weight loss medications like Ozempic?
Right. Okay. So first of all, to start off with, I think just a clarification from a medical point of view. So in fact, the only registered weight loss medication in South Africa is Saxenda, liraglutide. So the use of the other medications, Ozempic semaglutide and Mounjaro tirzepatide, are off-label use, okay? They are registered actually for type 2 diabetes, but we use them off-label for weight loss. So I think that's important just to set the scene. Okay. There are weight loss versions of Ozempic, which is Wegovy, and Mounjaro tirzepatide, which is called Zepbound, are unfortunately not available in South Africa yet, but we hope that they will reach our horizons. But at the moment, we're using them off-label. It's also important to note.
Can you explain? So I think because I want to unpack it properly for our listeners. Yeah, when you say off-label, right? So we know that you can get Ozempic and Mounjaro as the medications here. When you say we use it off-label, what does that actually mean?
So what it means is that they are actually registered by SAHPRA, our Medicines Control Council, for type 2 diabetes, okay? And the dosage that we use these medications for type 2 diabetes is different to what we use in weight loss. So the molecules are exactly the same, but for type 2 diabetes, we use them in smaller dosages than what they are used for in weight loss. So I think that's very important to know in terms of patient management.
Fine. But am I right then? But we do know that Ozempic and Mounjaro are being given out to, well, not, let's say prescribed, even though it's off-label, to patients for weight loss currently by doctors in South Africa. Is that correct?
100%. And we know, in terms of medicines, many medications are used off-label, a wide variety of medications. And as long as patients are aware that they are being used off-label, I think that's an important thing. Yeah.
Great. So thanks for clarity. So now that we've got that out the way, and I think that was a very important point for people to understand,
Yes.
we'll go back to the question.
Why?
Can you clarify? We know that there's been a lot of medication around for many years, tablets, etc.
Yes.
And certainly when you started in your obesity clinics, we didn't have injectables.
Right.
Why is there such a popularity around now these medications, these injectables?
Yeah. So I think what's happened over the last decade or so is that the medical professional, those who are treating patients who are overweight or obese, we now look to classify or define overweight obesity as a chronic disease state, like any other chronic disease state. So, for example, hypertension or high cholesterol. And so we feel that the management then of obesity has to be chronic. It's actually defined by the World Health Organization as a chronic, relapsing, progressive disease state. And therefore, when we manage patients now, the emphasis has to be on the chronicity of management, because like hypertension, when you're treating the patient, the disease is controlled, but if you withdraw treatment, the patient will relapse. And for the first time in our history of weight loss medications, we now have medications that are actually registered for chronic use. And I think that's very important for patients to be made aware of at the initiation of therapy. These are not quick fix medications that you can use for 6 months and lose your weight and stop and be happy. These are chronic medications that have to be used correctly and under the supervision of people who are involved, medical practitioners, etc. The reason as well is why these medications have suddenly become so popular. I think part is media, the hype around celebrities. I have many patients who come in and ask me, they're using Ozempic and they want to look like celebrities. And why aren't they looking like celebrities? So I think that's part of it. And the other part, in fact, is that these medications not only do they help in terms of diabetic control, so sugar control and weight loss, but we say now they offer whole body promise. So we see that long-term studies have shown that these medications in certain population groups offer long-term protection in terms of cardiac, so heart, in terms of reduction in heart disease, various types of heart disease, protection against stroke, reduction in stroke, protection in kidney disease, liver disease. And these drugs, in fact, are undergoing many, many studies, and they're being looked at in managing many diseases far more than what they're actually being used for at the moment. So from a medical point of view, for the first time, patients who are at risk, for example, your diabetic patients or your overweight or obese patients who are at high risk for type 2 diabetes, progression to certain of, liver disease, to cirrhosis, high risk of stroke, myocardial infarction. These medications actually offer long-term protection and decrease the risk of these conditions. So I think that from a medical point of view is why they're so popular. From more a cosmetic point of view, why they're so popular is in terms of the weight loss that you can achieve with these medications. And what we've seen is, as a group, the GLP-1s, as they've sort of progressed, we see that the weight loss you can achieve in trials is getting more and more. We started off with Saxenda, which could produce, we saw around a 9% weight loss. Then we saw with the semaglutide around a 14% weight loss. And now, amazingly, at the highest dose of Mounjaro tirzepatide, we're seeing weight losses that are approximating around 22%. And those are weight losses that approximate that of bariatric surgery. And these molecules are actually more and more being developed now. So, yeah, I think that's why they are so popular at the moment.
I was going to say that. I was going to say it's great, the long-term effects, and we're going to get onto that and discuss in terms of studies and side effects. But probably to me, in terms of the way I would see the population, I'd say it's probably because of those that last bit that you mentioned in terms of they just it's magnitudes above what are other options in terms of medications that we've had previously. Would that be correct to say?
Yeah, there have never been medications that have been able to produce this kind of weight loss. But more importantly, if we're looking at using them chronically, the maintenance of weight loss. So we've never been able to offer that to patients. If you look at figures of even in the best clinics, they're very poor in terms of very low numbers of patients are actually able to sustain that weight loss long term. And it's not a fault of the diet plan or the exercise. It's just as a result of the normal physiological response of the body. You know, our bodies are trying to kind of preserve our set point. So once you actually reach a maintenance goal, there are various mechanisms, physiological mechanisms that occur in the body that actually try and preserve our weight, and the patient reverts to their original weight, moves back to their set point, just as a result of our physiological need to preserve ourselves in a sense. So maintenance was a huge issue, and now these medications offer a realistic chance at maintaining that set point, lower set point, I should say.
Mark, while we're on setting the scene, what are the thoughts from your side?
Yo, I have so many questions, Charlene. Actually, I don't even know where to begin when it comes to this.
I know.
Just
It's
before we go
a huge topic.
Just before we go on, and I just wanted to, because I just thought in the intro, well, are you happy that we call you Charlene and not Dr. Wolberg on this podcast?
Absolutely. If you're happy, I call you Avron.
That's it. Perfect. Mark, go for it.
All right. Unfortunately, I don't have the doctor title, so you guys are going to have to just go with Mark, but I'm okay with that as well.
Great.
Yes.
I want to start off the discussion around this because it's interesting to me. If we're talking about something like Ozempic, and we're talking about things like PEDs in the fitness industry, right? And they've been around for a long time. You know, steroid use has been around in the fitness industry for a very, very long time. And a lot of people would liken Ozempic use to the weight loss version of a guy that wants to grow muscle. This is a lady or a man that wants to lose weight. So my first question for you, Charlene, is when it comes to Ozempic, all right, what would you say, what would be the point that a casual person that is overweight, where you as a medical professional would say, this is the right time for you to look at something like Ozempic? How many avenues would you suggest in terms of safety need to be exhausted before something like Ozempic becomes the medically prescribed alternative? Or is something like Ozempic something that you would say, yeah, you know, if you're someone that wants to lose weight, this is a great thing to just start off the bat on. You know, you don't have to do other stuff. You can start this. It's perfectly safe. And I think that question jumps into, to our knowledge, what are the safety parameters of something like Ozempic? And I use Ozempic just because it is the name that's going around social media. So I feel like it's the easiest thing to talk about. But I mean in all those different products.
100%. Okay, so first of all, I think that's a great starting question. So unfortunately, Ozempic, as any other of the previous weight loss medications, is open to abuse, okay? And it's a huge issue which we do have. So in other words, there are many compounded versions which people are using. Many patients are getting prescriptions and using it without proper supervision. So I think at the outset, we need to say that, you know, there is a lot of abuse going on, and that is not condoned by the medical profession. We have clear guidelines in terms of when we prescribe medications. at the outset, I want to say that whenever trials are done on any of the GLP-1s, the initial starting point is lifestyle modification. So I always say that to patients under the ideal circumstances of trial settings, lifestyle modification is initiated first. And only once that lifestyle modification is in place do we then initiate drugs. And what I mean by lifestyle modification, so classic lifestyle modification in trials is a calorie deficit of about 500 calories per day. So it's a very balanced diet. They recommend 150 minutes of kind of a mix of physical activity per week. These patients are monitored by psychologists and in terms of behavior.
Sorry, Charlene, when you say 150 minutes, sorry to cut you off, I just want to clarify.
No problem.
Do you mean, is that your non-exercise activity thermogenesis, or is it purely your activity thermogenesis? So exercise, or is it like taking the stairs, that part of your 150? Just as an understanding for the exercise base for the person.
And Charlene, you're talking to an exercise expert here.
I was just going to say, please excuse me. So my field is not exercise. So simply we know from trials, they give them 150 minutes of whatever a week. It's normally it's a mix, I think, of cardiovascular and whatever, resistance strength. I'll leave that to you.
Right. Okay, fine.
And then basically, candidates who qualify for weight loss medications have to have a BMI of greater than 27 with at least one comorbidity. So comorbidity would be either hypertension, hypercholesterolemia, insulin resistance, so something like that, or would be a BMI of greater than 30, so an obese patient. Just as an aside, BMI has just been phased out, so there's a new clinical definition, but we're using that for trials at the moment. So it's only patients like that who would qualify for weight loss medications.
And Charlene, sorry, again, just to clarify while you're there, you said that BMI is being phased out. Is it being moved to something like a hip to waist ratio now? Is similar along those lines? Because BMI is obviously going to be leading for the non-average person. And again, just around that question, do doctors have to fall within those parameters? Is there a governing body that strictly adheres a doctor to meet those parameters? Or could a doctor sit and go, well, you're not quite there, but you almost are, and I'll recommend it? Will there be repercussions for something like that?
Yes. So to answer your first question in terms of BMI, so it came out in the Lancet, which is kind of our Bible journal this year. The argument has been, and I'm sure you know from a gym perspective, how useless BMI in terms of ethnicity and muscle mass, etc. So we now take into account other measurements, waist to hip ratio, waist to height ratio, and then in terms also of disease state of the individual. So it's more moving towards that. Second answer is definitely, it's a clinical decision. So for example, if I would have a patient coming into me who I can see in terms of family history and their history have a genetic predisposition to being overweight, have been overweight their entire lives, have been yo-yo dieting for the last 40 years, sitting with 10 comorbidities, but is not quite the BMI, I certainly would consider that patient for weight loss medications, and there would be no clinical, repercussions. It's ultimately the clinician's decision, and it's very much a clinical decision. And those are, as I mentioned, just trial, criteria for trials. But within a clinical setting, you have to take into account the patient's perspective. And just to mention as well now is that it's a very difficult mindset to change in medical clinicians as well as patients to understand that this is a chronic disease state like any other disease, and you don't need to wait to treat with medications. The thinking now is to be aggressive early on.
I think that's a very important point, and we may have missed it when you were talking. I think the fact that being overweight or obese is now a clinical condition, it's a medical condition. It's not about just treating it because you've got high blood pressure or diabetes. It's about you the way it's now defined, Charlene, and you can confirm if I'm correct,
Yes,
it's a disease itself. And hence, if people say, yeah,
100%.
but if I'm going to be on Ozempic, I want to be on it forever. And we can talk about that as well. Yes,
Yes.
because if you're on diabetic medication, you have to be it on forever, and high blood pressure, you've got to be on forever. So you might have to be on your weight loss medication forever. Am I correct with that
You
understanding?
are 100% correct. But as I said, it's very difficult to change the mindset of both clinicians and patients who are, especially clinicians who are not in this field. Obesity is held by a separate set of standards. You will go to your clinician who is not involved, and they will say to you, it's energy in versus energy out. And it's not that. It's a very complex disease, and it has to be understood, and it has to be managed that way. Yeah.
Sorry, Charlene,
Okay,
just
so
a
I
quick
think
question.
yeah, go for it, Mark.
Sorry,
Sorry.
I've got a million questions here, so I just want, while they're fresh, I
Well,
just want to ask them.
As Charlene said, this could be a few hours, and we may have to do but
It
anyhow, go
really
for it, Mark.
is. Yeah.
Yeah. Charlene, would you say something like PCOS for women would be a suitable predisposition for something like Ozempic?
So
And
PCOS
could you
is an
just define, when we say PCOS, we must just say for our listeners what we're referring to there.
Polycystic ovary syndrome.
Yeah. So first
That's
of all,
it.
just to say that polycystic ovarian syndrome is an insulin-resistant syndrome at sort of the basis. So in my clinical practice, I would say probably a third of the women I see, of the younger women, obviously, have polycystic ovarian syndrome, and they are perfect candidates for one of the GLP-1s like Ozempic. In fact, many of the fertility clinics now, I always say I think they prescribe more than me, which is a lot. They prescribe one of the GLP-1s like Ozempic for their polycystic ovarian patients, because we know that a weight reduction of about 15% really improves these patients' chances of increasing their fertility and falling pregnant, without other interventions. And I've seen it many times over in my practice. So it's an amazing drug for these kinds of patients, not only in terms of the facility, but it also, many studies show unequivocally that it decreases the incidence of going on to type 2 diabetes. It actually decreases the incidence. A recent study came out now called the SELECT trial, and the SELECT trial showed that in these patients, it decreased the incidence by a quarter of these patients going from insulin resistance to type 2 diabetes. So that's huge numbers. Yeah.
Yeah, certainly. So are we satisfied, and Mark, you can tell me satisfied, do we are we happy with who would fit into the criteria of taking these medications? And do we think our listeners of the podcast would adequately understand who actually fits into the sort of the framework who would get this type of medication?
I think to a degree, yes, Aaron, but I think, Charlene, what I would like to know, and I think what would be nice for a listener to know is if, as an example, I think in your professional opinion, do you think something like Ozempic or whatever comes after Ozempic, because let's be honest, this is probably the starting phase of even
Yes.
greater medication in the next, let's say, 5
100%.
to 10 years. Do you think that just weight management is going to move to a medically controlled space in terms of health? And as a medical professional, do you celebrate being able to control weight with medication in the long term? Because again, if you look at if you look at gyms across the world and people's main goal, if you look at 80% of people are mostly in the gym because they want to lose weight and they want to feel a little bit better. And at the end of the day, being within certain parameters in your weight is healthier for you. And I think we can all agree. There's a lot of professionals on the planet that disagree with that, but I think the majority of professionals agree. And with being within your weight parameters does lead to a longevity of life. Would you as a
Yes.
professional celebrate the medical control of weight in the future, where it becomes the norm to just control your weight to a certain standard with better pharmaceuticals?
Okay, so I think there's a few answers to that question. So first of all, I want to highlight that weight loss medication is not a substitute for lifestyle modification, and it never will be. I think people need to understand that. Okay. I learned many years ago from a professor in the field who actually became the principal scientist at Novo Nordisk, who is the drug company for Ozempic. And he said to me, it was it was about older drugs, but it actually it's actually relevant to all kind of weight loss medications. These weight loss medications, really their aim is to enable patients to put those lifestyle changes into place. So in terms of certain patients with dietary, this eat less or mindful eating, you must understand that certain patients have certain genetic, underlying genetic conditions that they are not able to make these correct lifestyle modifications in terms of eating. So, for example, their satiety signals, their appetite controlling signals are actually not functioning as they should be. So, all their, the mitochondrial, the genetic control of their metabolism of food is not as it should be. So really what we're looking at with these medications is to kind of level the playing field so that they're able then to put into play those dietary practices. The second part of it, which is a whole discussion in and of itself, is that if you start using GLPs without exercise, you are at a huge risk of losing muscle mass and of losing bone mass. Okay. So one of them...
That's a really, really interesting that you just said. That was going to be one of my questions. So if you don't mind just focusing on that bone density question, because I've seen a lot of research that's highlighting bone density loss. And I wanted to just understand, is that when you're moving away from exercise, specifically weight training exercises, is that the cause of that? If you can just dive into that a little bit.
Yes, with pleasure, because it's a very important point. And it's something that is very close to heart, because when patients are abusing Ozempic and not putting those changes into place, we are seeing those consequences. So a very recent study came out. There was one looking actually at bone density. So you have, first of all, just your regular population, but then you have your high-risk population, like perimenopausal, menopausal women, and then your older population. So the different populations are obviously at different risk. But in general, if you get rapid weight loss with GLP-1, you are definitely at risk for losing bone mineral density, and you do become osteopenic and ultimately osteoporotic. The only way you can prevent that is by exercise, and as you said, at strength resistance training, together with an adequate protein intake. So then there is no substitute for that. There's no magic pill you can actually take to prevent that. So that also answers your question, would I be happy if everybody was medicalized in terms of their weight management? Well, if they needed to be in terms of chronic management like your antihypertensive, so then I would be if it would maintain their weight. But they would have to, and I insist on that with patients, you have to be exercising properly and under supervision. Same as with the drug. Like if I went into a gym now and you told me to do a resistance program with whatever, I would have no idea what to do. I would need supervision. Same with the dietary. Patients have to have a certain amount of protein in their diet. You need supervision by a registered dietitian. So that's the bone story. Same thing, and I'm sure you've seen that and aware of the muscle mass story with GLP-1s. There's a lot of mixed evidence. It's a lot of heterogeneity in terms of the figures in studies. It can vary anywhere from 40 to 60%. You can be losing muscle mass in terms of, of your total weight loss. So the reason that there's a lot of heterogeneity is because people starting muscle mass obviously plays a role, just in terms of genetics play a role in how much muscle mass they lose. So again, when you are using a GLP-1, you have to exercise to build up your muscle mass, and you have to be taking in protein. So that is absolutely essential.
Yeah.
And as you say, the thinking now in medicine, for the most important indicator at this point in time, they are saying in terms of longevity and well-being is actually muscle mass.
Yes. And we've
Yeah.
spoken a lot
Charlene,
about that on the show, but it's so great you bring that in. So, Charlene, would you say if someone came into you and said, I would like Ozempic, but I'm not going to exercise and I'm not going to go to the gym, would you be at a point when saying, well, then I'm not going to give you Ozempic?
So I'm very strict about it with patients, very strict, because you know what? Ultimately, I mean, as a medical professional, what do I want? A skeleton who's completely unhealthy? No, part of the journey of weight loss is to improve your health and well-being. That is what these drugs are designed for. They were not designed to, produce these skeletal figures that, in fact, you've worsened their overall health and well-being. These are medical drugs, and they need to be used properly and for their actual indication. Otherwise, what benefits are you actually getting long-term? You're doing more damage to these patients.
Sure. And would you say in South Africa... Sorry, Mark, go ahead.
Sorry, just one thing, Charlene. Would you be able to just explain the mechanism of these drugs in terms of how they work? My understanding is that they do work with an insulin-resistant part,
Yes.
and they also work with a satiety part. They make you feel fuller when you've eaten less, so you don't overeat. And does it suppress ghrelin, or is there another mechanism that actually? And just to explain to the listener, ghrelin is the hormones
Hunger
released that
appetite.
makes you want to eat.
Yeah. Okay. So just remember is that they're two separate things. So in terms of the type 2 diabetes and in terms of the appetite. So first of all, in terms of appetite, how they work. So the glucagon-like peptides, the actual hormone itself, it's a copy of a natural hormone that we have that after you eat is released from the gut. And it goes centrally into, first of all, the hypothalamus, which is the appetite controlling center. And I was very proud of you that you said it increases satiety. It's not an appetite suppressant. It's a very subtle difference, but it increases patients' feeling of fullness, okay? So when you would eat your whole plate of food, you're now going to eat half or 3/4 of the plate of food, which needs to be a balanced plate of food. Okay, that's the one area. It's also important to know is that these GLP-1 receptors are actually scattered throughout the brain, okay? So the complexity of their mechanism of action is actually not fully understood yet. But we do know it also works in areas of the brain that control what we call the hedonic attachment to food. And that's the emotional attachment for food. So how I explain it to patients is you've eaten supper and you're full, but you go and sit down in front of the TV and you know there's a packet of chuckles in your pantry. So you think, I'm just going to have 1 or 2 chuckles, and you take out the packet. By the end of the evening, you've eaten the whole packet of chuckles. So what it does there is it kind of dampens down those responses so that you are, as normal people do, have a couple of chuckles, but you're able to stop. Those areas also, they produce very subtle changes. So when you listen very carefully, which I make notes of, patients' descriptions of how they feel on the GLP-1s, they sometimes you'll see patients describe that they no longer feel like drinking coffee, sometimes alcohol. You'll note, just as an aside, they've been looked at in terms of addiction and decreasing addictions. So sort of a change in preference of the kind of foods you eat, and that is as a result of the workings in those areas in the brain. The third thing that they do is that they delay gastric emptying. So that basically means that your food stays in your stomach for longer, so you feel fuller for longer. So then it enters your intestines slower and enters your bloodstream a little bit more slowly. So you have nice, consistent blood sugar levels, and often patients describe they feel better because they're actually having nice, consistent blood sugar levels instead of these like spikes and dips throughout the day. So that is how they work in terms of appetite control. These molecules have far-reaching effects on all other organs of the body. So we know in terms of glucose, they have effects on the pancreas. And what they do is that they affect the insulin release from the pancreas. So you have sort of a delayed release of insulin from the pancreas. Again, this helps controlling blood sugar levels. And what we have in the pancreas are they called beta cells, and those are the cells that help in the functioning and production of insulin. And what they do is they improve these beta cells, they decrease sort of death of the beta cells, so that beta cell function is improved by them. I don't want to get too technical. If I'm too technical,
Yes.
you could slap me down. Then they
So
have
do you
positive
release-
effects in the liver.
Do you release less insulin, or is it just delayed?
It's a delayed. So it's what happens is after you eat something, you get a good release of insulin as a result of this. So then it lowers your blood sugar level appropriately. I won't get into too many technical details, but you don't get lows from this drug because it only releases the insulin after you've eaten a meal. So it's also safe in terms of that.
Forget you why you potentially, if you don't work out, have a rapid decrease in muscle mass because of insulin being such an anabolic hormone as well for muscle production. Because there's a delayed response and you're not training, you don't utilize the insulin like you would in a normal situation.
Yeah, definitely. That could definitely be part of it. Absolutely.
So if you're
Yeah.
recommending to a male looking to lose weight, obviously it becomes a very, very essential situation for a male to then do resistance training in combination with this drug.
100%, 100%, both male and female.
Yeah.
100%. And as I said, there are the at high risk groups like the perimenopausal women, older patients who already have got some sarcopenia. So yeah, you've really got to insist on resistance training.
And would you suggest that there's a supplementation that you can use if you're using something like Ozempic, just like a calcium with a K2? Would that be a benefit to keeping your bone density up, even if you are doing resistance training and doing everything right? Is that a good supplement to use in combination?
Yes, it definitely would be a good supplement. In fact, articles are coming out. It's quite scientific, but they're looking at a particular molecule now. It's in research and developmental phase to look if you take it in conjunction, that it'll actually decrease that muscle loss. But it's an experimental phase at the moment. Yeah,
that's very interesting. Let's keep up. So, Charlene, let's move on to we could talk about maybe the elephant in the room or something we haven't spoken about, right? And in terms of side effects, we asked both short and long-term side effects.
Yes.
Where are we in terms of understanding that? Relatively new medications on the scene. A couple of years, a lot of worries. A lot of people ask me about
100%.
this, Mark as well. Where are we standing in terms of that?
Yes. Okay. So, in terms of the molecule was actually discovered in around the 1960s, 70s, but only in around the 1980s was it looked at in terms of its diabetic effects. And the molecule then Victoza was only brought on about 2005. So it's only about 20 years. So it is new. And that is worrying in terms of long-term because we don't have long-term data. The only thing we do have is that because these molecules have been coming out and registered and re-registered, we have large numbers of participants going through trials. That's what we do have. And the trials have produced the same side effects and the same kind of complications. So the commonest side effects that you see, and this is across the board with all of the GLP-1s, are initially patients can be nauseous. You can see vomiting. You can see reflux because of that delayed gastric emptying. And then gut side effects, either constipation or diarrhea. Most of these side effects are minimal and pass with time. And if they are introduced slowly, which they should be, that minimizes the chance of side effects. Okay, so those are the commonest things we see. In terms of, there are always, side effects at the bottom of the list. You don't normally see, but sometimes you do see some unusual side effects. The things that have come up most recently that have been added to the package insert, so they have been around gastric motility and the slowing of gastric emptying. So, and this gastric paresis, which is sort of a paralysis of the GI tract. So, it is very unusual that you do get, I've never seen a case of it, but it has been reported. So now on the package insert, if you are going for any kind of anesthesia, you have to stop the GLP-1 at least 1 week before you go for the anesthetic, and to tell your anaesthetist that you are on it. Just because of the delay in gastric emptying, they would be worried that you still would have some gastric contents in terms of reflux. Okay.
Mhm.
The second two side effects are the increased incidence of pancreatitis and cholecystitis. So that's increase in inflammation of pancreas and gallbladder. In the studies, that has been increased. It's a very small increase in incidence, but it is increased. Just to mention, weight loss per se can increase the incidence of cholecystitis, inflammation of the gallbladder by itself. It's normally minimal, but I warn patients, if you get severe abdominal pain, you have to present at a casualty. You have to tell them that you are on a GLP-1, and it normally passes, but that is correct. The last one is the thyroid cancer, which always comes up. So the story with the thyroid cancer was that there was, in the studies, an increase in incidence of something called medullary cell thyroid cancer. What they failed to mention is that it was in the rodent studies. It was never in the human studies. Okay, and as far as I know, we don't treat rats. So, however, we do not, there is a warning that we do not treat patients who have a family history of medullary cell thyroid cancer, obviously patients themselves. I take it further, I don't treat patients who have had any family history of any form of thyroid cancer. An article came out in January of this year, a European study, which said there was no link and no increase in incidence in thyroid cancer. So that's that one. It's not safe in pregnancy and breastfeeding, so please don't use it. If you do fall pregnant on it, you stop immediately.
Right.
Okay, anything else you picked up
No,
on TikTok?
I think that's right. Because I think, and I'm going to hand over to Mark now, just in terms of side effects, but I think also, and we've seen this in terms of studies, like one has to go back and see, well, what was that saying? What does it show? Example, you're showing thyroid cancer, yeah, but that wasn't in humans. It doesn't mean the risk doesn't exist.
Yes.
But also,
and you need to be cautious.
I think one has to take a step back and saying, okay, well, you've got the risk of being, and it's a disease, right? You've got a risk of having a severely or high BMI, however we want to define it, or being obese, which has its own side effects and implications, versus bringing down the weight and significant decreasing your risk of disease going forward. So anything you take or put into your body, there's a risk, right? And I think 100%. It's about weighing up the risk. Is that the correct way to look at it, Charlene?
100%. As with any medication, it is a medication. It has side effects. It is a chemical substance, and you have to. It's risk versus benefit. Yeah, definitely.
Mark, on your side, did you have questions on the side effects and risks?
Not necessarily questions. I think it's just important that a listener understands that the side effects that are mentioned here, I mean, a lot of those side effects, I'm sure Charlene could mention for vitamin C tablets, for multivitamin tablets. It's everything that's ever recorded on something is a list of side effects. So as you said, Aaron, I couldn't agree more with you, is you have to really weigh up the risk of you being overweight and the list of proven diseases that come with that versus taking something that can possibly regulate that, and the smallest that is present, don't get me wrong, of taking the medication. But I think that from my side, and I think this is a very important question for the casual day-to-day person, and for someone that works in the gyms that sees us kind of every day, I can without a doubt tell you that people that want to get their hands on this will get their hands on this, whether it's through a medical professional or through a black market person. It's just unfortunately the way that the industry works is people want to get something without going to pay a doctor, whatever fee it takes to get to the final point. And then they might not even get prescribed the item that they want because the doctor might disagree that they need it. So, Charlene, you do not have to answer this. This is me poking in the dark. In terms of the casual person, if someone went and got Ozempic through the wrong channels, right? I think for me, always important to educate people because it's not the best case scenario we're looking at. It's the factual case scenario that we're probably going to be dealing with.
Yes.
What are the dangers of someone using something like Ozempic that doesn't know how to use Ozempic? I think that's a very, very important question because I know without a shadow of a doubt, people are going to be using it, and people need to understand that there might be really serious side effects and consequences, or there might not be really serious side effects and consequences if you follow exactly what you've just said now. If someone trains and changes their lifestyle, can the wrong use of Ozempic be detrimental to their health? Or is there like a good leeway in terms of dosage on Ozempic?
Yes,
that's
good
a great
question,
Mark. Really
yes,
great.
It really is a good question. So first of all, my intro to that is where they're getting it from. You need to know, and this is a problem worldwide, that there are no compounded substances that have been registered anywhere on this planet. Okay, so that's number one.
And
The issue with
Charlene, what you're talking about there is, because we do, and I just want to educate that there are compounding pharmacies where we have heard and we do know that you can potentially get Ozempic-like compounds from. Is that what you're referring to?
That's what 100%. So SAHPRA in South Africa has not registered, there's no registration for any of the compounds, FDA neither. And I continually get warnings from the FDA, please advise patients, I know here, so Novo Nordisk themselves have actually laboratory tested some of the compounds and they're problematic. I know at the moment there's a compound being produced that is a combination of semaglutide, so Ozempic, and tirzepatide Mounjaro, and that is contraindicated, completely contraindicated, and that will result in serious health conditions. So that's number one. You just got to be careful. I mean, I tell my patients, please, you need a prescription. You need to go to a pharmacy. It's either from Eli Lilly or Novo Nordisk. Okay, so that's at the outset. You don't know what you're taking. So in terms of complications, you actually don't know what complications you're going to run into. Okay. If, say, you do get the proper medication and it's unsupervised. So really, they're actually very safe medications to use. First of all, is because there are actually no interactions with any other medications, which is amazing. So it's a whole different talk in itself, but the use of these medications in psychiatric patients has opened a huge field in terms of helping these patients, many of which have gained weight from their psychiatric medications. So it's a whole other topic. But just to know that these medications actually do not interfere, or there's no interaction with any other medication. So that's very, positive to know in terms of safety, whether you need a vaccine or a painkiller or an antibiotic or cortisone, they're safe to use with everything. They don't interfere with mood. They don't interfere with sleep. So from that point of view, they are safe drugs to use. Just in terms of dosing, so it would be with any other medication, is that if you stick to the prescribed dosing regimen, again, you should be fine. The adverse effects would only really be the adverse effects that I have described. And again, your risk of the more serious adverse effects would obviously be increased if you were using doses higher than the recommended dosage. So they actually are safe medications in terms of general usage. Your problems would be, as I said, long-term. If you're using it as a quick fix, really what's going to happen is they have detrimental effects in terms of your metabolic rate, as yo-yo dieting does. So it would be the same thing, losing the weight and then regaining. And so that's really would be a long-term, your major problem. But beyond that, they are actually safe drugs and relatively easy to use.
So, Charlene, just to answer it, just the key question is your answer is that you shouldn't get it from the compound pharmacy because you actually don't know what they're putting in that compound. It's not the fact that potentially that's probably the real risk and danger. And that's
100%. That's the risk and danger. You actually don't know. It's just because it's unsupervised. That's all.
Yeah.
I just don't know. Patients will come and ask and I'll say, well, I just don't know. It's like with any, sometimes they come with herbal preparations. Say, I just don't know. You just don't know what's in it.
Okay.
So I think that's
Okay.
the answer.
And then in answering your question, there's $1 million question as well, because a lot of people ask me this, and Mark, I'm sure you get as well. So you've used it for a year, you've lost your weight, you're doing well. If I stop it now, right, but I carry on gymming and exercising, etc., will I regain the weight? So is it actually a lifelong commitment to taking it?
Yes.
Or if I stop it, what do the studies actually show on that?
Yeah. All the studies show the same thing. So what you see in the studies is you start off at your weight, you start the medication, and you see the major weight loss occurs within the first 6 months, and then you kind of start plateauing as you do with any weight loss program. As soon as you stop it, what you see, the graph goes slowly like this. You slowly start drifting up, and it doesn't matter what you do.
Even if you're eating excellently, you've cut down what you eat, you're exercising, lifestyle, everything,
It's the
you're
same
going to
story
put the weight back.
as your antihypertensive. So say you're on it and you are afterwards, you've been exercising, cut salt restriction in your diet, whatever, meditating, that blood pressure will go up because it's your set point. It's your physiologically, genetically predetermined set point, and your body is just preserving yourself. However, we have seen in studies, if you taper off slowly and don't stop immediately, there is a decrease in the incidence of weight regain, and that's very important. So patients who we do try give them patients a chance, because some patients actually do manage, but their chances of maintenance is much higher if you taper the drug off slowly, okay? And keep them there's a whole school of thought which now is called microdosing, which we're looking at in terms of maintenance. So it's another whole topic for a talk, but you can see that. Also, patients need to understand, and that's where gyms come in, is your best weight maintenance tool is exercise. It's your muscle mass, because that's your metabolically active tissue. Your best chance of maintenance is going to be if you are consistently exercising and keeping that muscle mass up. That's really, more so than dietary. In fact, during the maintenance phase,
But if you start this, you're on for a long time. It's not a short fix.
So no, it's not a quick fix. It's just not a quick fix. Yeah. It's a medical
Mark,
drug.
I'm sure you've got a lot of questions on that. Your mind's buzzing around that one, but it's very interesting.
It's a hard one to wrap your mind around. It's more difficult to wrap your mind around that than being on a cholesterol medication or a blood pressure medication.
Yeah.
No, I mean, again, for me, it does make sense. I understand that, again, a lot of these things are treating physiological issues that have nothing to do with calorie surplus situations. Yeah. And as you said, Charlene, a set point often makes a lot of sense with a lot of people. And I think it's a lot more predominant in women than it is in men. I think that estrogen, unfortunately, fights females in weight loss versus testosterone. I think an important question, and probably be my last question for you, is, as you said, people are going to be on this for a while. What are the cost implications of being on something like Ozempic? Number one, is it by your medical aid? And number two, if you're going to be on private healthcare, what are you going to pay roughly every month to be on Ozempic?
Yeah, that's a great question. And that's a question worldwide. In fact, articles are literally just coming out, and they come out not only in medical journals, but in like The Economist, etc., is the cost. The cost is a huge factor. And unfortunately, patients who need it cannot afford the drug. These are very expensive drugs. They are talking about generics, actually, fortunately. So that's a huge issue. Just to set the playing field is that weight loss is considered cosmetic by private medical funds. So that's a huge problem. So in terms of reimbursement, you will get nothing for weight loss. And it's around the world. It's a huge, huge issue. It's a fight.
Yeah, Charlene, is because we started this conversation saying that, obesity is being diagnosed as a chronic disease, but you've got medical aids that are not step into that space and pay for something. It's such an interesting kind of conflict between what you would think would be a green board in terms of...
You would think medical aids and funds, and I'm sure this is a hot topic for you, Charlene, so we're getting you going on this.
I think you need the actuary from the medical aids.
But you would think, Mark and Charlene, that I would say that medical aids and funds should be handing this out in the streets to those who need it, because it's a disease and it decreases long-term disease and mortality. So it's like saying people have diabetes, but we're not going to treat diabetes, right? So that's sort of what I'm understanding. Is that correct, Charlene?
Yeah, this is such a hot topic, and oh my gosh, they're saying that the way we're going, by like 2035, half of the population is going to be overweight or obese. We haven't even spoken about childhood obesity. The numbers are staggering, and this country, the numbers are even more staggering. So it's a huge thing. I
think maybe we got to come back and do a show on that. There are two questions from my side that I think we're going to, because time is starting to run short, but I just want to tackle and just answer, because listeners have come to me on this, is firstly, if someone comes to you and said, and I mean, the answer here could be long, but maybe we can try and keep it brief. I'm weighing up between doing a gastrectomy, which used to be the old way of treating this. That's a surgical procedure to give similar effects, or take Ozempic. What would you say to them? And my second question is, if you could, a two totally different question is, the new type, say a Mounjaro, how does that sort of differ to Ozempic? So if we could, those are my last two questions, and if you could look at answering those.
Okay, so first of all, the answer to your first question, bariatric surgery versus medication. So it depends if you land up in my office or the surgeon's office. You'll get two different answers. So in my office, just by the way, I want to add in that bariatric surgery is covered by medical aids, and it's thanks to actually Professor Tessa van der Merwe, who really fought that battle many years ago. So what we do is now we try first with medication, because Mounjaro tirzepatide at the highest dose, the weight loss can approximate that of bariatric surgery. However, if you have a patient presenting who has medical emergency, so in terms of the type 2 diabetes, it is completely uncontrolled. They have other comorbidities, which we haven't spoken about, like sleep apnea, and so they really are in a crisis, then you would actually go for bariatric surgery, because in terms of bariatric surgery, the remission of those conditions is very much quicker than with medication. So that's kind of a very short, simple answer. Okay.
So, but if you don't have those urgent conditions, rather go long-term.
You would try the medication first. Fine. Yes, definitely.
And Charlene,
the difference.
The Mounjaros, the newer ones that are coming on stream now.
Yes. Okay. So the earlier GLP-1s were what we call single agonists. So they had one single GLP-1 agonist. Tirzepatide, Mounjaro, is like next up in the field. It also has a GLP-1, but it has a secondary inhibitory molecule called a GIP. So it's like another inhibitory molecule. So therefore, in studies, we see that the sugar control is better, as well as the weight loss is higher. There is now coming out in about 2006 or 7, a triple agonist, which now has a third inhibitory molecule. So watch the space.
Would you start someone as a Ozempic or Mounjaro, or taper it, or if someone coming to you now in 2025?
Yeah, well, I've had this dilemma for the last 2 months. It's a very individualized decision. So it's no blanket answer. It's really going to depend on the patient, where they are. Have they been on a GLP-1 before? There's no uniform answer. It's definitely an individualized assessment.
Got it. Mark, any last questions for Charlene? I know it's been a jam-packed show, and I'm going to say we're definitely going to bring Charlene back, but anything you want to finish off with from your side?
First of all, just to thank you for being on. I think it's a lot of questions answered, especially for people that are very interested in this topic. I think the last question for me is, and it's just a rough amount, because I know that I'm going to get messages from people saying, like, what is the actual cost? Just a rough number. If someone's going to go on something like Ozempic, what are they paying per month?
Yes. Okay. So it's going to depend on the dosage. Okay. So at a regular pharmacy, so the starting dose is 0.25 milligrams. So a small pen costs roughly 1,800 Rand a month. If you're on the 0.25 milligrams, that pen will last you 2 months. And if you're on the next dose, which is 0.5, it obviously lasts you 1 month. The bigger pen, which is the 1 milligram, which I think most patients land up being on, is around 2,700 Rand a month. So I think that's roughly what you should bank on. The Mounjaro, which has just come out, they actually have come out in vials to cut the cost because it is exorbitantly expensive overseas. We are like highly subsidized. So each vial costs about 900 Rand and you need 1 vial per week. So you're looking roughly at about 3,600 Rand. Okay. What's interesting though, which I can't understand, is that with the Mounjaro vials, is that as the dose increases, the price doesn't increase of the vial. So, yeah. So that would be your, yeah.
So, Charlie, we're looking at, say, between 500 Rand and 1,000 Rand a week, a dose on average, Mark. That's probably where you're looking, and it's, in most cases, you're going to have to fund that yourself.
Yeah, I know with these medical aids, it comes out of savings and it's very complicated, but at the end of the day, you're paying for it yourself.
But listen, if you're not going out for your steaks and cappuccinos and burgers, then maybe you can say, well, I'd rather pay for that medication.
That's it. With the older drugs, I used to say to patients that money you were going to spend on the chocolates, put it in a jar, and at the end of the month, you'll see how much that adds up to.
Charlene, thank you. It's been fantastic. What's your key message as what we can finish off with for those considering weight loss medication?
Yeah. My key message is it's not a quick fix, and lifestyle modification is essential. You will get the best results from these medications if you use it in conjunction with healthy lifestyle modification in terms of dietary, healthy diet together with exercise, which must be a mix of both resistance and cardiovascular. And the whole process should be supervised if possible. Yeah.
Charlene, Dr. Charlene Wolberg, thank you so much for sharing your thoughts on this trending topic. It's been really insightful. Mark Hughes, thank you so much. It's been so valuable having you in as a co-host, asking the questions. And I think, Charlene, we're definitely going to have to bring you back because there's a lot of questions and topics we didn't touch. An hour's gone, and we feel we've only touched the surface. But it's been really enjoyable, insightful, and just thank you for your time that you've given us.
Absolute pleasure. Thanks for inviting me.
And just to tell our listeners, if you've enjoyed this episode, subscribe, share, and join the conversation by leaving your questions and comments. Until next time, feed your soul with knowledge, kindness, and self-care. Thanks, everyone, and goodbye.
Thank you.
Thanks.
Thanks.
Let's talk.